Hi guys, so in this short video we're going to talk about behavioral abnormalities and motor activity. So let's start with motor activity. So what do they mean when they say the patient has got psychomotor retardation? Psychomotor retardation, when you think about this kind of a patient, it's someone who's just very slow. They are just slow in everything. So motor, look at motor as gross movement, like the whole body. What is the whole body doing? So someone who's got psychomotor retardation, they first of all, they move as a unit. You know, when we walk, we swing our arms as we are walking. We can easily turn around while we are walking. We can easily look what's happening there. Someone who's got psychomotor retardation, they don't do that. They move like as a unit. They move like this. Their arms will be on their sides. They're not swinging. Then they're walking like that. And as they walk, it's like their neck is stiff, or they are carrying something very heavy, a very heavy load on their head. So they will be walking like that. If you shout from the back, they will turn like that. And then they will look at you. And they are so slow, you would swear that as they are walking towards that direction, it's like they don't know what they're gonna do when they get there. It's like they're thinking, what will I do when I get there? Because they are very slow. Even when they sit as a unit. When they stand up as a unit. You hardly find them. You know, when we stand up, we would use our arms to lift us off the chair, but with them, they sit like this, and then they stand like this, and then they start moving. So someone's got psychomotor retardation. Everything with them is just slow. It's like they've got some kind of a brain shutdown. It's common in depression, this kind of a clinical picture. So there are drugs that can make a person to look like this as well. And then you've got psychomotor agitation. Someone who's got agitation, this person is like restless. They don't sit down. They are forever. It's like that kid who's got ADHD. They can't sit down for long periods of time. They would sit down now, and then the next minute they'll start moving around, and then when you call them back, they'll come and sit, and then once you continue the interview, they'll start moving again. Some of them would even want to go outside to show that they're not running away from you. They would come back when you call them, or when a relative brings them back, they will come back. They are forever doing something. They are forever moving up and down. They are forever, they will even be looking at the windows. They are making these movements, but they are not important movements. It's not movements that they need to be making. So some of them would even get to a point where they are irritated and they are argumentative. No, why should I sit? No, why should I sit? Don't want to sit. No. Things like that. They are hardly, if they have got this, they are hardly like physical and all of that. They don't like beat anybody, but they're just, and when they say they want to move sometimes out of the room, you trying to call them back, that's when they would start to argue, or you ask them to sit on the bed. One moment they'll be sitting on the bed, then the next minute they're sitting on the chair, then the next moment they want to go outside. So they're just doing something. Unlike these ones, This one, you can ask them to sit, they will sit up until you ask them to move. That's psychomotor agitation. And also, one other thing that you also need to observe here is eye contact. There are some who will be avoidant. They don't want to look at you in the face. Some of them would be, their eye contact is just appropriate or it's not appropriate, in the sense that maybe they they stare at you, some not even blinking, things like that. So you look at their eye contact. You know, an appropriate eye contact, I mean, if I'm talking to you, there's no way I'm going to look at you forever up until we are done talking. There are moments where, as we are talking, I'll look away as we are talking. But it's not appropriate for me to look away all the time when we are talking. That's not appropriate. So there should be moments where you look at me and then moments where you look away from me. That's fine. But don't overlook at a person, or don't just look away all the time. That's not appropriate. So you look at the eye contact. You ought to look at the level of cooperation. Are they cooperating? Are they not cooperating? And all of that. Someone who's cooperating, when you call them to sit, they'll come and sit. If they're not cooperating, an agitated patient is likely not to be cooperative. But a retarded patient is likely to cooperate. Okay, now the next thing is, so this, we said this is like the gross motor. What is the entire body doing? It's retarded or it's agitated. And then now, when you look at the specific movements that are maybe area specific, is it the limb, or is it the trunk, is it the head, is it the neck? So that's when now you pick up things like ataxia. Oh, this patient has got ataxia, or this patient has got tremors, or this person has got dystonia, or this person has got tics, mannerism, echopraxia. You know, echopraxia is someone, it's a pathological imitation of someone's movements. Just like echolalia. Echolalia is someone who repeats what you just said. What is your name? What is your name? They normally repeat the last word or the last phrase that you said to them. What is your name? Or this way. What is your name? Your name? Your name? Your name? Your name? Where are you coming from? Coming from? Or from? Things like that. So that's echolalia. But with echopraxia, they repeat the movement, the last movement that you have made. That's the movement that they're going to repeat. And then you can also have what other movement? You can have tremors. You can have tremors. You can have chorea, purposeless JK movements. You can have catatonia. You can have negativism. Negativism is not negative symptoms. Negative symptoms, I will talk about them in schizophrenia, they're different. Negativism is someone that is maybe sitting and you want to help them to stand, or you want to move their arm. They are resistant to that. They don't want. They are resistant to the movement that you want them to make. Even if you come and assist them, maybe you try to help them stand up, they will resist that. That's what is called negativism. So guys, there's no way we can cover everything, but these are the common movement disorders you're going to see, things that you must look at. So remember, when you see a patient, comment on the psychomotor, comment if there are any other abnormal movements, level of cooperation, eye contact, all those things. And you can also add other things that I didn't include in this chart. So guys, that will be it. Let me now take a shower to work. Thank you so much. I'll upload more later this afternoon when I come from work. Thank you.